Okay, let's get underway. Hello, everyone. My name is Felicity Barr. I am a broadcast journalist and communicator, and I am delighted to welcome you to this session entitled From Commitment to Action, Implementing and Monitoring National Cardiovascular Health Plans Post-UN High-Level Meeting. Now, we all know that cardiovascular disease is the world's leading killer, responsible for more than 20.5 million deaths a year. Yet too few countries have their own dedicated specific plan on cardiovascular health. In fact, CV disease is widely recognised as being pretty much under-prioritised when it comes to health planning and, of course, when it comes to finance. So the WHF is right now developing its framework for a cardiovascular health action plan. In fact, there are a few copies around at the moment. It's not completely finished, but this is the framework as it stands. So it's going to be a comprehensive but adaptable model with practical tools which will help support individual nations as they develop their own CV plans. There is a growing global commitment to tackling non-communicable diseases, but how do we build on those commitments, transitioning them into actionable strategies that are well-resourced and accountable? Well, this session, which is kindly being supported by NSD, will examine the most effective ways to sustain cardiovascular health plans across the world's diverse health systems. Our panel of global experts is here ready to share their experiences with you. But first, let's hear from Eirini Agapidaki. She is Greece's alternate Minister of Health. Sadly, she couldn't actually be with us today, but she has recorded this keynote address, which we can share with you now.
Ladies and gentlemen, esteemed colleagues, it is an honor to join you today at this important side event of the World Health Summit. I thank the World Health Federation for convening a platform that moves us beyond declarations and into the real work of implementation and accountability. Cardiovascular disease remains the leading cause of death worldwide, claiming more than 20 million lives every year. In Europe alone, we continue to lose 5,000 lives each day, while health systems spend hundreds of billions of euros managing preventable complications. Yet, despite the alarming toll, cardiovascular health is too often subsumed under broader NCD strategies without clear targets, dedicated financing, or robust monitoring. This must change, and change begins with political commitment backed by concrete action. Only a few years ago, Greece's health system was highly hospital-centered, with prevention often fragmented or inaccessible. The COVID-19 pandemic magnified this gap, disrupting screenings and leaving undetected cardiovascular cancer cases across the country. Rather than accept a wave of avoidable deaths, we acted decisively. In 2023, we launched the National Prevention Program Prolambano, which is the Greek word for prevent, take action beforehand, before symptoms manifestation, before the problem appears. So this is the first population-wide organized screening program in our country. It offers free, easily accessible preventive tests for cancers, cardiovascular disease delivered through a fully digital pathway. So far, more than 4.2 million citizens have already used the program out of 6 million eligible citizens. Public satisfaction for the program exceeds 90%, proving that prevention can be simple, trusted, and equitable. Building on this, in February 2025, we introduced the National Cardiovascular Rescreening Program, targeting 5.9 million citizens aged from 30 to 70 years old. This group contributes most to premature heart attack and stroke, as well as to premature deaths in our country. In just months, 2 million citizens have completed blood testing and risk assessment. 35,000 people have progressed to advanced coronary disease assessment, while now 1,000 individuals have already undergone ischemia testing. All services are completely free of charge, accessible in more than 15,000 locations nationwide. What we learned: number one, political commitment and sustainable financing. Prevention must be a budget line, not a pilot project. embedding our program into the National Recovery and Resilience Plan unlocked long-term viability. Simple digital access. Citizens receive an SMS or an email referral. Those offline can visit any participating center with only their national ID or health insurance number. Technology removes bureaucracy and builds trust. Number 3, enabling factor, equity by design. We integrated public facilities, mobile units, and private providers to reach even remote islands and rural areas. Geography cannot dictate survival. Number 4, data-driven accountability. We track participation, detection rates, health outcomes in real time. These indicators are vital to adjust policy quickly and maintain public confidence. Greece's experience shows that large-scale, publicly funded cardiovascular prevention is possible and sustainable. But no country can act alone. As the EU Cardiovascular Health Plan moves closer to adoption, we need coordinated governance at EU level, aligning recommendations with national implementation frameworks, dedicated European funding streams for prevention integrated into health and resilience budgets, shared indicators and surveillance tools so we can measure outcomes comparably and learn from each other. The World Health Federation framework for National Cardiovascular Health Action Plan is an invaluable guide. It encourages governments to define priorities, cost interventions, and track results across 4 pillars: policy, financial commitment, risk factor reduction, health system strengthening, and equitable services delivery. Greece is applying this logic already, but its power multiplies when shared. Colleagues, we have the science, the tools, and now the political momentum from the UN high-level meeting on NCDs. The question is whether we will translate it into real measurable change or people's lives. Let us move from strategies that exist on paper to programs that exist in people's neighborhoods, where a text message can trigger a life-saving screening, where rural communities have equal access, where prevention becomes a social norm, not a privilege. Greece stands ready to share its lessons, learn from others, and contribute to a Europe and a world that chooses health instead of illness. Thank you.
Pretty powerful words from the Minister. We do thank her for taking the time to record that address. I particularly liked the statement, geography cannot dictate survival. Okay, let me now introduce our panel. So, next to me we have Dr. Ami Banerjee, who is Professor in Clinical Data Science at University College London and Honorary Consultant Cardiologist at UCL London Hospitals and Barts Health NHS Trusts. Next to him is Dr. Guilherme Duarte. He's the Executive Director of Unite, that's the Parliamentarian Network for Global Health. He is a medical doctor with a specialisation in public health and has served as a diplomat in Geneva, overseeing health affairs for the Portuguese government. Olivia Ngou is the founder and Executive Director of Impact Santé Afrique. It's a female-led NGO focusing on health advocacy, community engagement and building gender transformative health programmes. Olivia is a public health specialist who has been working for more than 10 years in the fight against malaria. James Anderson is Executive Director R&D Innovation at the International Federation of Pharmaceutical Manufacturers and Associations. He was previously Head of Corporate Government Affairs at GSK. And Dr. Zainab Samed is Professor and Chair of the Department of Medicine at the Aga Khan University in Pakistan and Adjunct Faculty, Duke University. Now, her clinical and research efforts are focused on understanding the epidemiology and outcomes of heart disease. Welcome to you all. Thanks so much for being with us. I mean, Professor Banerjee, I think we should start with you, given you're helping the World Heart Federation shape this important framework. What gap is this framework aiming to fill, and why is it so timely right now?
Thank you, Felicity. So I am a board member of World Heart Federation and advise in this area. I think it's well known from an epidemiology point of view, as you said at the beginning, that cardiovascular disease is a huge burden on people and health systems, and there's good evidence about what we need to do. The gap, as you say, is how and where we do it, the implementation bit. And these action plans, I think, are a way of prioritising at the national level so that human and financial and policy resources concentrated in this area, from the screening for disease through to the treatment and prevention as well.
And it's taken some time to put together, I can imagine.
Yes, yeah, because you're pulling together the evidence in a way that's accessible to policymakers, but also there's a lot of documents and work that has been done at World Heart Federation before, such as what are called roadmaps. So those are adaptations of guidelines that are specific to areas of prevention or treatment or particular diseases such as rheumatic heart disease. So we're trying to take from all those, as well as the literature as well, to give something that can be adapted at national level, because this isn't a one-size-fits-all.
Dr. Duarte, you have that rare blend of experience as a physician, diplomat and a policy leader. What do you think are the key policy levers that can help countries translate those political commitments that we've heard about on cardiovascular health into something that resembles concrete national action and investment?
Absolutely. Thank you so much for having me. It's a pleasure to be here. A very quick presentation to our to my organization. So I come from Unite. We are a network of parliamentarians for global health, and we promote evidence-based policies. So my first quick answer to your question, I would say that a streamlined agenda. So I feel that we are very much, and I think WHS is a perfect example of this, we have a very much a state of confusion in terms of the true priorities. If a policymaker or a decision maker, whatever intentions and with the best of intentions would come into the WHS, it would be very confused in terms of what it should do the next day in terms of the national health systems. I mean, we do argue that all the priorities are the most important thing to budget, etc. So I think that it's really the first thing, it's to make a clear case for it. And I think the action plan, it's a very good start. Perhaps it needs a little bit shortened for a policymaker because the two-pager is already a bit too much. But out of a joke, I think that it's the perfect first step to identify the next steps. So I would say that, of course, a clear budget to allocate, and this is very much needed. This will be the internal work that the policymakers will have to do. Not only parliamentarians when they discuss the budgets in the parliaments, but also the members of the government when they discuss internally where to put the budget lines. So I would say that this is the second one after the clear case. The second thing probably empower the health systems as they are. I mean, it's important to strengthen primary care systems. I'm sure that, and I've already seen this, something written here, the importance of also counting with the full range of the health system. There are technical packages such as the WHO Hearts that can be used, and I'm sure that they were also listened to. And then on the third, probably mobilize innovative financing ways. Nowadays, I think taxpayers are very less inclined to put more money on the table, so I think it's very important to have these innovative financings. And lastly, I think speak of one voice. It would be great if we could get a number such as, for example, the 1990 for HIV, which was a great way of involving community, involving lawmakers, decision makers, in a very, very, very simple way on how to make it achievable. And so I think this will allow the last step, which is accountability, which parliamentarians can definitely support, so that together in 10 years we understand if we're reaching that or not. And if we're not, then we need to put more pressure.
Interesting, you've just mentioned community. Olivia and Ngou, you've led powerful advocacy movements across Africa. What lessons have you learned, especially from those community-driven and gender-transformative approaches, that you think could be applied to national cardiovascular health action plans?
Yes, thank you very much. Basically, engaging community from the beginning is key. Engaging them in the design of strategies, of interventions, whether it's communications or even program interventions or even designing prevention interventions. So working with community not as beneficiary only, but as decision makers and equal partners to co-design those strategies with them is really key, because then we are able to actually respond to the need of those communities and to really have communities at the center of the national strategies. And then the next step is implementation, ensuring that community and civil society have a role in the implementation of those strategies, because they are with families, with people, and they can play a vital role in prevention, even detection of first sign, etc. So their role in implementation is key, and especially in areas where the health system, there are areas, unfortunately, in Africa, where the health system cannot reach all the communities. There are villages where there's no health centers, no health workers, or health staff. So in those areas, in particular, communities and civil society role are crucial, because they are the only forces, and they are actually doing, at the moment, great job on HIV, malaria, tuberculosis prevention, and why not integrating now cardiovascular diseases issues into what they are already doing in the community. And in those remote areas, you rely completely on them, and they are able to even bring new data to the Ministry of Health about some of the cases or the problem that we see in those communities. And then there's also conflict zone. Unfortunately, in this world today, particularly in Africa, there are so many conflict areas where the government or the health system do not even have access, and where the only people who are able to access those communities are the community members themselves. So in the conflict zone, they're even extremely important. And then the last point is on monitoring and evaluation. So throughout the implementation, ensuring that communities and civil society are part of the monitoring and evaluation system is key. For example, in malaria, in HIV and TB, we have a community-led monitoring mechanism, and this is something that we can include and integrate, because we've been talking this week about more integration, especially in this context with global challenging context. But the community-led monitoring system is actually looking at what the beneficiary thinks about the services, prevention services or treatment services, even after treatment services. Because nobody really look at the beneficiary, what they think of the services. First, do they access services? Do we have gender barriers or financial barriers or social barriers or any type of barriers that prevent them to even accessing services? And in this case, it's information. We are seeing an enormous increase of death due to cardiovascular diseases, but do people even know, they don't even have the information to understand what is happening, because they might have their own interpretation about a sudden death, which can mean many things, but access to information and monitoring by community, what the beneficiary think, what they know, if the services was of a quality or not, is key. And in all that components can help the ministry to actually have a greater impact.
Lots of nodding around the table to everything that you've just said. Let's move from community to the private sector, which we know has played such a pivotal role in shaping global health responses, James Anderson. From your perspective, what is the best way that public-private collaborations can support countries who want to implement and finance cardiovascular health action plans? How do they work together?
Yeah, thanks very much. So it's really a pleasure to be here, although we're at the end of a long 3 days for some of us. So thanks, everyone. Hope you've had a coffee before we started. In the question that I was given in advance to prepare on, it was to look at lessons learned to answer your question from other areas, which I think are very relevant. So, and the two that was stated was pandemic preparedness and AMR. And so the way I would start to answer that is, is what can we learn from doing that? So first of all, it is absolutely the importance of planning and preparedness and prevention. I mean, I think in cardiovascular disease, it's so well known and so frustrating, as you said, that the medical clarity is there. It's just not happening still. And so 80% of deaths can be prevented. And that's why I think frameworks such as this, from from a group such as the WHF really do help. I think the Greece story is fantastic, right?
It's amazing.
We would all love to see that replicated elsewhere, and it is happening elsewhere in different ways, but needs to be accelerated. So that's the first thing. Secondly, the private sector absolutely does play a critical role and is committed to carrying on doing that. So what do we concretely bring? Clearly, we do develop new medicines and vaccines. Actually, we should come back to the role of vaccines in this, because I think it's often neglected, but even sticking on the core medicines. And we have a level of responsibility that we take very seriously to try to get them to people who need them all around the world. But we can't do that all on our own, because actually when you look at the pathway that any medicine has to go through, and you touched on sort of the later stages of that, it has to be an end-to-end pathway all the way from coming out of the laboratory and the factory through the regulatory system, through the selection process of the country, which is done in very different ways, through the physical distribution, and eventually to the patient in a place where they can receive it. So we are companies such as MSD, but all work in that way to try to facilitate that as far as possible, but it's not something that can be done on its own. So engage all the way is good. And the third one, just being a little bit more almost philosophical about your question, companies like to be asked to help, right, or to be involved. But at the same time, often it feels like companies are being told or sort of mandated or even coerced into trying to do the things that are maybe seen as helpful. So I would just encourage, so I was going to give one example again from AMR, which was after the 2016 UN high-level meeting on AMR. 100 companies came together and established the AMR Industry Alliance, which creates a collective platform to be able to engage like that. And the relevance is that we are exploring with MSD and other companies the idea of a CVRM alliance, which is still at a conceptual stage, but that would offer the opportunity to be a sort of a one-stop shop for approaching the industry outside. This would be more outside Europe, where there's already that type of thing, and in the rest of the world.
Sounds much more joined up.
Exactly.
Okay. Dr. Zainab, we know that data and evidence are central to guiding national cardiovascular health action plans. Now, from your experience, what are the key data and surveillance gaps that need to be addressed to strengthen that accountability and impact, and particularly in low and middle income countries?
Thank you for that question. So I think I want to think about this in a few different ways. The first is that in a lot of low and middle income countries, and Pakistan is one of them, we are sitting with the mindset that we've got the reproductive, maternal, and child health agenda, which still is an issue in our country. Communicable diseases are still an issue, but NCDs are now raising their head and causing a huge problem for the communities, for families. But where is the advocacy? Where is the local research? Where is the contextual solutions? And for that, you actually need a research workforce, and that's a problem. You know, LMICs burden almost 60% of all of the NCD burden, but there is, when you look at the publication and the literature output in the global literature, less than 5% is coming from those countries. Okay, so that's something just for us to be able to think about globally as to how do you develop that research capacity and create the next generation of advocates in this space, which will then collect the data, which is how I get to your question. The second piece is, you know, data and quality, you need it. You've got to be able to point at something, then can you actually see it, and then you can do something about it. And where that data comes in is a few places. There are multiple different industries that are already gathering data, but their efforts are not coordinated, they're not talking to each other. The data goes and sits in some cupboard if it's in paper form, or sits in some computer system, and never mind, and you do not draw insights from it. So what we require is a lot of a coordination on that front. The second piece with the data is that in a lot of LMICs, we have what's called the vital registration system, but mortality isn't tracked. If, for example, in Pakistan, less than 30% of deaths are actually registered. And forget about the cause of death. We do have a medical certificate thing, but you get a paper and you need it for the burial, and then the paper is gone somewhere. It's sitting in some hospital system, never makes it to the central ministries, the decision makers. What is causing the deaths in this country? And what we make our estimates and what we make our decisions on are actually estimates. They're not real data from that place. I think that's, if we strengthen the mortality system, we would be able to not require so many surveys. This will be just an automatic inflow of information that then drives policy. The places where people get care, those are places that can actually get information and coordinate it, whether it's registry ways or whether hospital systems that want to improve quality as networks, they can actually coordinate and collect that information as well. And I really believe that the WHO, the WHF, I have great convening power. And this is where your role can come in, where you actually request that convention and coordination of data sources within individual countries. For surveillance, I think all of the data sources I just mentioned, they can be used, but we have digital exhaust of our internet connection that every single user in like a large country like Pakistan, almost 240 billion people, are connected. How can we get patterns of their behavior that we know are very tightly linked to cardiovascular disease incidence and outcomes? And so can we use that information that does not require, is not expensive? That data is sitting somewhere. Can we use that information to actually guide action in those countries? And finally, I would say we talk about policy, but very little is done in terms of putting down indicators to show that the policy was actually implemented. We put down very nice strategies, but nothing comes of them. And you go back to that country 5 years later and nothing has moved. And so can we make our citizens, make our governments accountable for action on those policies that have been put down? So that's
Lots of nodding, particularly from Olivia at that point. I want to also talk to you a bit more about AI and digital a little bit later on. We'll come back to you on that. Dr. Duarte, Unite, as you've said, mobilises parliamentarians right across regions to champion stronger health policies and accountability. But how specifically can lawmakers ensure that CV health remains that sustained priority within national and global NCD agendas? What should they be doing?
Yeah, so very short, very brief version.
Go on.
Doing their job. To complete. Of course, parliamentarians have very specific powers in their range and in their terms of reference that actually make them very great advocates for this. The first, doing legislation. I mean, that's one of the powers. You can only do it, at least in most democracies, either in a government, cabinet, or from the parliament. And so legislators owe this key to actually produce very evidence-based, very great policy aligned with what's the technical challenges. And so this is something that also Unite as a network tries to promote. You're just mentioning AI now. Yesterday we had a very nice presentation about the Global Health Policy Lab, which is a very nice tool that you can just scan all the action plans that are around there, and that this is a very interesting tool to be used in the future to actually produce. We don't believe that there's a one law that fits all. Of course, communities are very different. You have to take into account the cultural sensitivities, etc. But you can make a law that it ticks the best boxes in terms of the best practices anywhere. So I would say that the first thing lawmakers can do is actually good legislation in terms of very aligned. The second, budget scrutiny. This is also in the parliamentarians' powers to actually decide budgets. Usually, governments have to take the budgets to the assembly to be discussed, to be legislated. So I think they hold here a very important role in terms of discussing which budget line should be put it there. So I think this scrutiny is also very important, sometimes overlooked even into their powers, but I think it can be used responsibly and very wisely. The third thing, which I was already mentioned, I think, several times here in the table today, is accountability. Not only through the community voice, but through the parliament. questions to the government, parliamentary inquiries, all these tools can be made to actually ask the government, hey, what are you doing? How are you advancing the priorities? And also that sometimes that is something that is overlooked, and Unite tries to also respond to that. Sometimes governments make huge commitments in terms of the global health. They make in the UN General Assembly, in World Health Organization, and then you go back to national level and nothing is done. So you feel there's a disconnect between global priorities and national priorities, and so parliamentarians can also be strong advocates to make sure that the government is following what they promise in this forum. And lastly, just as a regular citizen, but with a possibly stronger voice, or at least the best position, they can still do political advocacy for all these topics. So I'd say that these 4 things are the very important role of parliamentarians, and we as a network would also try to promote their role into these 4 things.
Okay. Professor Banerjee, I want to do a slightly deeper dive into the WHF framework. When it comes to designing, implementing and monitoring cardiovascular health plans, what are the key pillars, do you think, of the framework that countries themselves should be prioritising?
Thank you. So, first of all, you need to prioritise, as Dr. Duarte said, and you can't do everything. So there needs to be some context specificity. Are we talking about stroke, heart rhythm problems, and preventing diabetes, or are we talking about heart attacks and rheumatic heart disease? So we have to pick the kind of 3 or 4 key priorities. And then I think the point that Dr. Zainab made about the data is critical. Whether she was talking about death, but we need to have ways of monitoring what services are available, whether they're used, what the outcomes are, and regularly monitoring that as well, so that we can say, so priorities, targets, based on data, and that even in middle and high income countries is not always well done. The ideal would be to have routine care data, so that you're not having to do surveys and sampling and doing that disease by disease and duplicating. Ideally, at the point of care or at the point of public health, you can gather that data, and there's lots of examples where that can be done across diseases, but it's not always done. We tend to have our silos. So another thing, perhaps, to think of, that we've been thinking about is increasingly we recognise that cardiovascular disease, in its risk factors, but also its outcomes, overlaps with other non-communicable diseases. It's important to say that because we're at the World Health Summit, we're not at the Cardiovascular Health Summit. And so this, because cardiovascular disease is so common, there's an opportunity to when you make the action plan overlap and make relevance to the other areas of action that are happening within the policy domain. And our colleague from industry was talking about vaccines. We don't think usually of the overlap between cardiovascular disease and infectious disease, but we've learned that in the last 5 years that, for example, cardiovascular disease and diabetes and obesity are the biggest risk factors for getting hospitalized and dying from coronavirus and flu and pneumonia. And so you can't think of one without the other. So actually cardiovascular disease is relevant to both. And I think what he was alluding to is the fact that vaccines are, in their effectiveness, really good for cardiovascular prevention. We don't always learn that as cardiologists. I'm a cardiologist. And we're more interested in other tablets and other treatments, but vaccines and infectious disease prevention or treatment are very good, very effective for cardiovascular prevention. So this kind of cross silo thinking will push us forward as well.
I guess, James Anderson, that's music to your ears.
Couldn't have put it better.
Olivia, I mean, civil society, we've talked a little bit more about community, but civil society can play a critical role in turning those political commitments into concrete health outcomes. What strategies have you personally found to be most effective in ensuring that communities, youth, women's organisations become proper true partners in designing and implementing national health plans? What works best in your experience?
So in our experience, what worked best, one of the things is actually the collaboration we have with policymakers and parliamentarians. Because civil society, we do make a lot of noise, pressure, emails, letters. But we found out that when we go into a meeting with a government or implementer, with an MP, with a parliamentarian, we have actually a lot of attention. So we've been collaborating very closely with parliamentarians. We've been inviting them to the ground, to come to the ground, to see, to speak with community, to see the services, to hear directly from the community, doing those ground visit and ground trips. We've been taking them to hospital, to talk to the medical staff, to also understand the issue that the medical staff have in terms of the fact that they are also overwhelmed in very low numbers, and they're having to do many reports, etc. So taking them to the ground, civil society and parliamentarian together, once we go back to the national level, it makes things a lot easier. Because the when we will do our advocacy, the parliamentarians will say, yes, I saw this was true, and this is not acceptable, and this has to change. So that is one thing that is that has worked well for us. Second element is we also have other allies, which are the media, because we know that some decision makers do care about what the population, public, and the media talk about. So we have identified a set of specific media that are interested in health, who are focusing on health. So we invite those media, we train them first on the issue, and then we go also on the ground with them, or sometimes they go without us to media visit. And when they come back, we have created coalition of media on health. And we are now able to link them with the professional, because sometimes they also don't have the right information at the right source. So we link them with expert professional in the health field. But then we also want them to talk about the gaps, the needs of the community. And that also making sure that in the media there are communication or highlight visibility on this issue. It's a powerful highlight, because it actually help to give attention to the issue. And then lastly, besides the media, the parliamentarians, we just started to do it now, is to also start working with local mayors. In some countries, there are local government, because we realize that at the community level and at the local level, those local mayors, local governments have huge impact also in terms of monitoring of policies. Even now, we're talking about domestic funding, we want them to invest more in disease prevention, because they do have funding, and sometimes what they do is they go into the community, they buy a lot of things, they distribute to the people, to the population, and for them, they feel like they've done a great job, and we say, no, we want more sustainable, programs to help fill the gap that the ministry have, and think about how, with that domestic funding, you can actually support community health workers, women's group who are doing prevention and all those things. And just one big lesson is that all those allies we have worked with, at the beginning, we found out they had no information and no idea about the situation. No, they didn't know, even in terms of funding, they didn't know, they thought, oh, international, we have global fund grant and this grant, but this is a lot of money. And when we actually explain to them that it's not even covering the need of your country, and sometimes so now they do understand that actually we are in a terrible situation. So the access to information, to working with those allies is very important.
As a journalist, I might come back to the role of the media a little bit later. But I wanted to move, you were talking about funding. James Anderson, we know that financing is obviously always a key challenge for national health initiatives. Based on your experience with financing models like the AMR Action Fund, what opportunities do you think there are to mobilise sustainable investments and align incentives for those long-term cardiovascular health outcomes?
Yeah, thanks. Really, really great question. So briefly, the AMR Action Fund is an industry-led fund where a number of companies came together to fill a very specific gap in antibiotic development, which is that the economics of antibiotics, when they're launched, doesn't support the R&D, right? So there's a real break point, which means that there are very few antibiotics in development. That's a big problem. Companies recognized that and came together to try to bridge the gap until governments actually introduce economic incentives, which they've been talking about, and some have, and some are others in progress. So I think that's not such a direct model here for what we're talking about, but there are others. I think many of us have been in sessions here and elsewhere. So one I would call out is the Pandemic Fund. That was set up under the G20 during COVID because it was recognized that, and it is part of this, investing into local initiatives to identify and understand emerging outbreaks quicker and better. And that is still on the infectious disease side. But that's, I think, for me, resonated a bit with what you were saying about building infrastructure so that we know what's going on more, right? If you don't have that, how do you get started? That's one example. Then another one is, and that's funded by governments and development banks and public sector groups. Another one that's different is under the Access Accelerator program, which is another industry consortium that's worked with World Heart Federation for many years, but has now sort of evolved the model a bit to focus on helping countries attract money from the World Bank, primarily. And they do that following 3 principles, which I think are very sensible and should be used more broadly. And interestingly, the Pandemic Fund also kind of uses these principles as well. So the first one is that the countries have to own it, right? Own the application or the request, which means that providing technical assistance in a way that's relevant locally. So from outside the country, the technical assistance can be helpful, but only if it's translated into relevant. Secondly, in helping countries talk to each other and share learnings and best practices. Again, easier said than done, but that's something that they've been focused on. And then third thing is that having a relatively small amount of catalytic funding that in this case comes from the private sector, but doesn't really matter where it comes from. The point is a relatively small amount. It's sort of chicken and egg problem that can unlock the work that's then necessary to secure a very significant grant from the World Bank, particularly in this case. So I think that's a very different model, but Sol can help and is gaining some good traction, in fact, with that. And then the third one, which was really focused on in the Younger high-level meeting and all of the build-up to that, is health taxes. And I thought, for those that heard Dr. Tedros's remarks last night, he put it front and center again. And although many countries are moving down that route to introduce them in a way that works locally, and I think as the private sector, I don't know, Jesse, what you would say, but we don't like taxes per se. But when there's a sort of a no-brainer one like this, I think we need to be comfortable to say, yeah, okay. Right. So, and that, as Dr. Tedros said, can help raise money for health or for other purposes. It can discourage, the use of these products, and thereby can improve health directly as well as supporting healthcare provision.
More nodding going on across the panel on that one. Dr. Zainab, I said I really wanted to talk to you about AI and digital innovation. I mean, we know that they've been transforming and how we detect, monitor and manage cardiovascular disease, but how can they actually be integrated into national frameworks to improve prevention, care delivery and progress tracking, especially when it comes to, health systems that are resource constrained?
So while I have the mic, I'm going to put in a plug here.
Go on.
So here's the thing, we are witnessing a transformative technology, like literally it's like front row seats at this. And it's coming, the technology is evolving at like warp speed. And the literature that is evaluating this technology is a little lagging, but it's coming out, but it's sitting behind a paywall. All right, that's a problem for low-income countries. If we're going to say that this is a global technology, it has transformative potential, why would you put it behind a paywall? So I think that's my plug, and I'm done with that. I think in terms of AI and incorporating in frameworks, we need to think about it from a patient community perspective. How does this tool help the person who's got the disease or is at risk for disease? And how does it help the system that is going to take care of that patient? Now, from a patient perspective, there are open source tools that they can go to get knowledge. And I think the media can also now very quickly use those tools to put health literacy information out. This is something that we keep thinking in cardiovascular space where women are concerned. They don't know their symptoms. They don't know when to go to the doctor. And so how can we use some of these AI tools to, one, combat misinformation in this space, but actually put out trusted information into the hands of the people whose health it is? So that's one piece of it. And that information may be just awareness, but also if they've got a disease, and frequently patients come to my clinic and they don't know what medicines they're on. They don't bring their medicines with them. They're like, oh, I don't know, is this the blue pill? And I'm like, okay, can we use some of these transformative technologies to actually just give the information to them? They hold the phone up to the pill and the phone tells them this is this pill and this is what it does for you. And so can we be thinking about really bottlenecks around information, the correct information that the individual needs to take better care of themselves and screen themselves? So this is one aspect of it. The other is the system. How can the system be improved to take better care of patients? Whether we introduce, and the system, by the way, you've got to make sure that the system can actually pick up this technology. Do they have the staff, space, training, and the infrastructure to kind of get the data required for the AI algorithms? But then at that end, can it be used for logistic efficiency within resource-constrained environment? Can we use risk stratification tools that become, very easy for a physician sitting out in the basic health unit to use? Can we use some of these tools to train and retrain the physicians? Can these act as point of care pockets of knowledge as the physician needs them? Here is a patient I've got. How do I move them from atenolol, now that this person's got renal disease, to another drug? How do I make that conversion? Instead of a phone a friend, they can pull up a tool and actually ask that question. So how can we use some of these tools to even help the providers and keep them up with training? And then finally, I would say that for the researchers, this is a transformative technology. Getting the data, doing the research, the statistical support that doesn't exist in a lot of places, how can this technology be used to do that? And then for those research pieces that are done, how do you convert them to policy? I know the Global Health Policy Lab has developed this fantastic resource with AI, actually. How can we leverage something like that to put in the hands of the researchers and physicians to advocate with their policymakers? This is what we require on the ground. So I think thinking about this along the chain of the patient's journey and along the chain of the system that takes care of the patient would be a very useful way to go about it.
I'm actually interested in all of your responses to that about AI and data and how it can be leveraged. Please.
I just wanted to add two things. One is when you said like there's a lot of increasing information, or you used knowledge actually, but I would correct to information because sometimes cannot be knowledge, or knowledge is also confusing, and sometimes patient can also be confused, but that's life, and that's how it is. And then just a second thing to add to your intervention in terms of the possibilities of technology, the devices. I mean, nowadays with this device, and actually during COVID, I was doing contact tracing. I was doing actually public health medical doctor work before went to Geneva, and I felt my chest really heavy. And so I did this hard thing that as a ECG, and I actually identified auricular fibrillation. I was like, okay. So I sent to my brothers, they're both anesthesiologists. They're like, you're 34, probably it's nothing. Don't look at it. I was like, okay. I went to bed. The next day I remeasured it again. It was the same thing. I said, okay, I will call a colleague. I went to the hospital. I did a proper ECG, and I was with auricular fibrillation. I ended up doing first treatment with the pills, and then I did an intervention to revert it. Everything is okay. This was actually with a device. So, I mean, this opens a lot of possibilities, even in remote areas with everything. I was actually, later I was researching, apparently it's already under literature, etc., with the specificity and sensibility quite studied. So it actually opens a lot of possibilities, even to be included in these action plans. So just wanted to...
Yeah, and I want to add that, that it's an excellent point that you make, that the technology is sitting on your hand or on your phone, but you also have to include sort of how to make it low cost so that it can reach everyone,
Sure. Anybody else want to say anything about AI and data?
Yeah, this area of digital wearables is interesting. It's from in the UK where I work. The people who I want to be wearing wearables aren't wearing wearables, and all of the younger, fitter patients who are less likely to have the heart rhythm problems which you had are wearing wearables. So there is what's very well described as the digital divide, or the digital wearable divide, which we need to make sure that we're accessing the right populations and cost-wise, or depending on how the funding model is. And we don't want to use limited resources, particularly in lower income settings, on people who don't need to be seen. So we need to make sure these devices are evaluated. AI is transformative in its potential, but only with the right data. So, the global burden of disease, which we base a lot of our global estimates on, is not comprehensive data in a lot of the lower income settings. So we're imputing, we're from smaller data sets as to what the whole data is. So whereas in Scandinavia or in England we might have large population electronic health record data sets which are much more representative, we might have comprehensive mortality data. So how that data relates to the AI is important, because AI can't solve missingness and representativeness unless we test it. A good example of that is genomics, where 80% of the genomic data still in 2025 is from white Europeans, and yet 80% of the population is non-white European. And even that data that say, for example, about South Asians, it's South Asians like me who are living in London, not South Asians who are living in South Asia. So it's really important.
Which is surprising.
Yeah.
From my perspective, I find that.
So if we want to really get serious about precision medicine and these kind of potentials of AI, then we need to go to the water source.
Is it improving though?
It's improving. That 80% was more like 96% when genetics was kind of 10 years old. So it's slowly improving.
Dr. Duarte, with your experience in both global diplomacy and public health, what are you seeing as the most promising opportunities to strengthen the collaboration we've been talking about between governments, parliaments, international partners to scale equitable cardiovascular care and prevention worldwide?
So I would say that all the actors need to sit on the same table and decide really. I started the first question by saying that we seem to be in a constant state of confusion. So perhaps we need to solve this. We need to, collaborations like the WHF and with WHO, with the technical organizations, with the local hospitals and other primary healthcare centers, there are good starting points. We really do have to talk the same talk and advance the same objectives.
I also, very quick follow-up question to your previous talk about this alerting. Did you speak to your brothers again?
I did, of course.
Given they said no, you're absolutely fine.
Naysayers.
I did. And you know, when you're actually a son of a doctor, you'll realize there's a certain, I'll not say insensitivity, because it's not insensitive, but you take things a bit more relaxed, I would say. It's fine, everything was fine. It was not, very urgent, and it was taken care of. But yeah, they were surprised as well, I would say.
As the daughter of a doctor, I can truly attest to that.
Right?
Yes, you really aren't suffering. Yeah. It's absolutely fine, and then you go and find out actually there's something quite badly wrong. So yeah, I agree with you on that. James Anderson, we've just been talking about data, innovation, AI, public-private partnerships being crucial for monitoring progress and scaling impact. So what mechanisms do you see, what collaborations could actually help strengthen data-driven accountability?
Yeah, so it's been a great discussion on this already. So I was going to start off just with the fact that the innovation coming out of the industry on products is vast. In the area of NCDs, there's almost 10,000 medicines in clinical development at the moment, and that's something like 3/4 of the entire industry pipeline. So the innovation is coming. Then in terms of sort of how to, I think it comes, others have talked very well about the need to have the data so that we can understand how to use them well and in which patients and so on. So I was going to just sort of come back to the high-level meeting and the target that was included in the declaration that hasn't quite been adopted yet, and we'll see what happens to it, but which is the 150 million target for having 150 million more hypertensive patients under control. And this, I think, why I wanted to come back to this is because I think it pulls together quite a lot of the different things that we've been talking about, right? So one is, what's the point of a global target like that, when in reality those patients will only be treated if they are in a clinic somewhere and the right care is there and the right medicines are there. But I would argue that it is useful. Oh, and the second thing that I was going to sort of challenge around it, just in the interest of the discussion, is why pick hypertension? I mean, I'm sure you were involved in many of the negotiations there. Because again, so I think it is useful, but as we've said, it shouldn't be seen in isolation. So how do you, what does that mean? How do we balance it, and how do we all use that to drive progress, to drive, to drive activity? So I think the way I look at it is, having a target is useful because it should then catalyze conversations that wouldn't otherwise happen about how do we together do things that do move in that direction. What we've all seen, and others have expressed frustration, is when there is no follow-up on it. Because then it just has the feeling that this was not really a target, it was more like a, I don't know, a line in the sand. So I hope, and I think discussions like this, and groups such as the WHF and others, can use that to progress the work of that's in the framework of driving forwards towards it, whilst not losing track of the fact that it's not the only thing that we need to be working on. So bit of a meandering way, and I appreciate I haven't directly answered your question because I think others have actually covered a lot of it. But that was when I was thinking about, you know, where we are, where we were last month, and where we may need to go in the next months. That I thought was quite a way to bring it together.
I've got a confession to make. I don't know what the time is because I've just suddenly realised that my
6 minutes past 5.
6 minutes past 5. That's okay. I wasn't quite sure whether my iPad was showing me UK time or time here in Berlin, and I was thinking, oh my gosh, have I completely run over? But I haven't, which is great news because there's much more to discuss. Professor Banerjee, we started off talking about the WHF's framework. What are you hoping is going to be the biggest impact of that framework in helping governments deliver measurable cardiovascular health gains? What's your biggest hope right now?
I think you answered it right there. Actually, is that the implementation of what we know happens or is easier to do, and that they can forgive the pun, put it into action and measure it. I think if that happens, then that would be a huge advance.
And what sort of timescales are we talking about then for individual countries?
Yeah.
How long is a piece of string?
Yeah, so I think we have to work on political cycles. Don't we? We wish the commitments were longer than that, but I think definitely within a 5-year timescale and maybe less that we'd want to see that, because beyond that you're in the cycle of a different government.
Do people on the panel feel that's realistic, country-wise, to be able to implement over 5 years?
I think with the right political will and getting people are passionate about this together, then it is. I mean, it is possible to do it. You just have to make sure that you get the right people on board together and create the political will if it doesn't exist. Which
I was mentioning earlier, obviously, as a broadcast journalist, I'm actually interested in all your thoughts about how the media actually covers cardiovascular disease. Does the media get it, understand it, just pick on the few things that are actually easy to translate for the general public? What more needs to be done for groups in partnership with the media? Nobody wants to answer that one.
Can I start us off? I think that there's collaboration and work to be done in both the kind of public awareness, but also in the science as well. So I think people still see cardiovascular disease as something that's either inevitable or can't be prevented, can't be treated. It happens suddenly, and you know we're kind of in the hands of the Almighty, or you know, serendipity, as when actually there's loads of things that you know are in essential medicines lists at WHO. There's things that are in place in every country that we could do for cardiovascular disease, and there's definitely things that we could do to prevent. So I think that awareness, in the same way as across the world, I mean, unfortunately we live in an era where there's myths and disinformation as well, but I think we saw in the last 5 years where in certain instances there can be kind of mass education and awareness raising that can happen. I think we need to, the media perhaps with focused actors, both from the policy side and from the clinical or science side can do that. I was going to give an example from the UK where we have the Science Media Centre, which proactively has a pool of scientists and clinicians across the UK when a story comes out in the media to fact check it, or to, before it comes out, they ask for a statement, so that in an era where anybody can comment on anything, you have some experts who are able to counter that directly live in the media as the stories come out.
And I think probably it also depends on whether you're dealing with a journalist who specialises in science and medical matters, or a general reporter. And the reality is that newspapers, broadcasters, online platforms don't always have a dedicated health specialist. Yes.
Just to add one other thing is that I'm a doctor and I'm a scientist, but media training doesn't come to all of us.
And it should.
And it should. It should
Yes.
actually. It's kind of this kind of public awareness or media engagement should be part of our job.
Yeah, if you allow me my 5 cents, I would say that yes, what you just identified, I sometimes feel there's a technical or lacks technical depth to be able to cover things properly. I think sometimes articles or pieces they are not also clear on its objectives. Sometimes it's very ununderstandable what's the point of that. And nowadays, I mean, with the budget constraints in the media, sometimes you're always, or at least I'm always fearing that they're just fishing for likes or for reposts. Although there's still, I would say that there's still some good content. Usually, when there's collaborations with medical associations, patients advocates, although you have to take some of the hidden agendas behind, there's always a specific angle, either pressure the government or so you do have to take that into account, but it's usually nice material, or podcasts, which sometimes they're very confused with self-improving gender, even with medical doctors making the podcast with recommendations, or it ends up being diluted with all the same gender out there, maybe the nutrition with the apps, with the whatever. So I would say that it's a very interesting question. I think that could be improved, definitely.
When it works, it works. When it doesn't, it's not good. Sorry, Olivia.
Yeah, exactly. So depending on the context and in the country, at the community level, the media can be really great allies. Also because sometimes we are going to fight misinformation. And unfortunately, with social media, with WhatsApp, and everyone has a phone now everywhere. Everyone with AI, or because of AI also, everyone listens to any type of stories, to anything that is maybe not true. So it's quite important now to give media the right information before the spread of fake news and fake information. So what we realize is that many media will say, I'm interested in diabetes, I'm just going to go in Google and I find whatever information, and that's what I'm going to say on the radio. And then we say, no, you have expert of the district Ministry of Health. You have experts in your community. It's good if you go and interview them. You have the local doctors, etc. So providing them with a framework or a way to have the correct information help a lot, so that they can then sensitize the community with the right information, because we have this basic need now of accessing the right information and also giving the right information to the community, and that's very, very, very important. And besides just health days or specific days during the year where we see a lot of awareness around the issue, after that the whole year there's nothing, no coverage and anything else, and this has to change. But I think a strong collaboration, media with Ministry of Health at the community level, district level, civil society, NGOs, having them collaborate over the year, I think will help to increase the role that media can play.
Dr. Zainab.
Yeah, I think I completely agree with all my fellow panelists and what has already been said, and how media can play a role here in helping us combat this big problem sitting in front of us. One area that I think is, I think of media as our justice partners, okay? and they can really shine light on the areas, on the things that are not represented in our policies, in our frameworks. Where is it that the health system is lacking? Which health system has a big problem? How have we addressed gender? So those, and you know, accountability. How are we performing? When we said we would, the targets are important, the targets are good. How are we doing on the targets? And that is a creation of not only awareness around these issues in the general public, but also a little bit of a pressure on the decision makers and the implementers. So I think that is one other area that media can really, they can be our justice partners.
Jay.
So I also again really agree. I mean, I think what's you know quite fascinating is the stories that you've all told, and those are there are stories that the media could tell more of. And I suppose what's a little bit again in my head is how can we as a community help package those stories into a way that the media will tell them in a way that then, you know, mobilizes people and makes them more aware and educates in the right way and you know, corrects misinformation. All very real roles. So I think it's again, it's a sort of a shared thing. I don't know, I mean, I'd be interested what you think actually. Do you think that as communities of patients and medical professionals and others, even industry, you know, do you think we do we help you sort of help the world like this?
It varies.
Yeah.
I mean, it varies deeply. So I worked in the world of television, right, where there is less of a need to continually change your output compared to a newspaper online, which is looking for clickbait and looking for likes and to, you know, advertising. So that's a very very different model. I think you'll find with your broadcast journalism, they will work much more hand in hand with the medical industry, and in terms of you identify a story. It takes quite a long time if you're in television to go and film. That's where you commit funds and resources. Therefore, you're going to want to get the best possible story out of it. If you're working for a tabloid newspaper in the UK, you rip and read something that someone else has written, shove in a few quotes that may or may not actually be from real people, which we've had, and you churn it out. So it's a difficult one to answer. I certainly think that what you were talking about earlier about people in the medical profession having media training in knowing what journalists are looking for, different types of journalists, whether it's a general journalist, a health journalist, a particular health correspondent might be very much more interested in policy and politics, whereas a general correspondent will be looking for the human story. So, you know, I mean, your story about being diagnosed by that. I mean, that's instant. That's an instant tabloid headline of, you know, there you go. I mean, you know, that's an easy story for me as a journalist to be able to tell. It's not complicated. It's got something that people wear all the time. It's like, wow, that's amazing. What a great story. The in-depth world of a framework or public policy can be quite hard to translate. And it also depends on who your audience is. You talked about the fact that the people that you quite like wearing, you know, your fitness trackers aren't necessarily the people who are going to be wearing it. Or the people who you would quite like to read an in-depth article about cardiovascular disease and prevention aren't necessarily going to be the ones who read it. And that is, you know, hey, I'm answering questions. I've just been answering questions. Something's gone wrong with the panel. But yes, yeah, that's the reality of it. Is it depends on your audience. But I definitely think that you know, it can always be improved. And also the media has moved so quickly in the last 5 years as to you know, where it's going and what it wants. It's hard for people in the medical profession, the medical industry, to keep up, and things have to keep evolving. Andrea looks like she's about to tell me something. I was just about to say that, yeah. I mean, I don't know, does anybody in the audience, yes, have a question? Miguel, you're on with your microphone directly behind you.
Thank you so much. My name is Marcelo. I am a junior doctor representing the International Federation of Medical Students Associations. I just finished my term as regional director for the Americas region last term. I'm from Peru. We were doing in IFMSA a really good work on cardiovascular diseases, working at the community level. But my question was more directed on that we were talking about many things on putting the right stakeholders in the table. And I think that here youth can take and can play a really important role on the table in decision making, like being partners with all of you on making and creating really good strategies, really good policies in our community level, especially in the low and middle income countries. In IFMSA, and I'm saying this because I'm doing actually right now a master on public health, and many of the things that we did at IFMSA are things that now I'm doing in my master, and I say like, I already know how to develop health plans, like health policy plans, how to develop strategies, how to make a policy document, and how to like create good teams, like leadership teams, in a, you know, and the question that I wanted to make, and I wrote it because I don't want to lose the, and if I am allowed to be a little bit ambitious, I want to make two questions actually. So sometimes it demonstrates like how can youth then, organizations and medical student networks be systematically involved in national CVDs action plans to strengthen health literacy and counter obesity and cardiovascular risk factors through community-driven advocacy and behavioral change. And the other question that I had was with now the work that is being done in the intersection of AI, data science, and the media in which youth are really involved. How can then youth and early career professionals like me, that I'm just starting, and I'm actually doing my residency in Germany in cardiology, but my question is like, how then these early career professionals, especially from low middle income countries, can be empowered to contribute to CVD monitoring and personalized prevention through digital health innovation, given the growing data gaps and limited access to technological infrastructure in these settings?
Can I kick us off? Thank you. So we can't miss the opportunity to capture like that kind of energy and enthusiasm. So we've got to do something. So when I was at your stage, or you know, I probably looked older than you at your stage, but I did an internship at World Health Organization. So there are different organizations that have central and regional offices where you can do both paid and unpaid internships. Now WHO has paid internships, but there's various organizations you could go to. The Global Burden of Disease study has fellowships as well, which you can apply for and go, if you're that way minded and want to be involved in the data gathering and mapping side of it. There's ways to be more involved on the kind of public health in your own country level as well. I think the broader point there is really interesting, that we've got a really digitally literate younger generation, even the generation coming after you. And yet we have this structure in general that's quite hierarchical, where board levels of organizations tend to have the kind of hair distribution that I have, and even less than me. So how do you get people involved earlier in the conversation? Because otherwise they tend to get disenchanted and disengaged until they start losing their hair as well. So I think we need to get better at that. So I think, definitely get involved and ask would be my suggestion.
Does anybody else want to?
Yeah, sure. I think I can just speak from experience. So at the Aachen University, we have several student body organizations, and they've organized themselves into groups that have like internal medicine interest group, there's the cardiac sciences group. And I was sitting and we have these mentoring sessions, and I was like, you guys are doing a fantastic job. One thing, and speaking to the point that you raised earlier, is you pick a risk factor you want to work on and then make a dent in it. And if the body or that group literally takes a risk factor on, like, and I was pushing hypertension as one, maybe another group picks up another, then you know, okay, here are all the communities that we screened. Here is what we did with the blood pressure. Here's the literacy. So they act as almost the arms of the health system out there in the community. So that's one idea. And the other thing that you mentioned about, and I agree with you, a digitally literate population is coming right up in age. I think our young generation should be, and they already are, getting very savvy with AI tools. Be ambitious, be brave in using them, testing them, evaluating them, learning about them, and then be entrepreneurial in your mindset of how you could use them to create new solutions for the problems. And we mentioned so many while we were talking in this panel. How do you create something for a patient who can't, can you translate in terms of health literacy? I'm sitting from Pakistan, we're in the Sindh province. Can we get something that speaks in Sindhi to the population about their blood pressure, about their medications? So how can we, can we use this knowledge about problems and use that, then turn that into solutions? And I think our young generation can totally do that.
Anybody else? Or does that answer your question?
Yeah.
Does anybody else? Miguel?
And for that matter, I think AI should be integrated in the medical curriculum now. That's really important, I think.
Can I just add one really last small thing
do.
to that? Sorry, because I think, I mean, you guys do an amazing job here in this summit. I think in every panel discussion I've been in, someone from your student federation has asked a very eloquent and intelligent question, and I think we all see that and hear that. So that's a good start. So don't be discouraged with there aren't any easy answers. I think what you say, I again couldn't put it better. But I think doing what you're doing is an important step along the way, right?
And it's encouraging to hear that sort of a question, isn't it? Not?
Yeah, exactly. Yeah. Sorry, I was processing.
No worries. Thank you. My name is Anna Meltzer. I'm a public health practitioner, global health practitioner. And I have a question about, it's my first actually session at the World Health Summit, which is completely dedicated to non-communicable diseases, because I was looking more at data systems and everything else. And it's very educational. I learned so much attending today and reading the report which was provided. I have a question on monitoring ambiguous, goals. Is there a framework agreed upon on the UN high-level meeting? And is there an agreement on indicators, how countries can track this progress in those national plans? Thank you.
Everybody's looking at Professor Banerjee at the moment.
Oh dear. Yeah. So I don't think that it was agreed in terms of a particular metric at the UN high-level meeting. There have been, I mentioned in the preliminary work to this framework, we've looked through roadmaps, which are WHF documents on different diseases where there are, for example, if you're looking at a heart rhythm problem called atrial fibrillation, you look at stroke rates, you look at what proportion of the population are on the blood thinner, the anticoagulant that they should be. So those kind of metrics are there. Are there the kind of 3 or 4 catch-all metrics that we should have? Not yet, I don't think, is the answer.
Yeah, just wanted to add some context that on the high-level meetings and the negotiations of the texts, there's a lot of foreign affairs going on. There's a lot of diplomacy, so you cannot expect to be the most ambitious text. Member states, they take a lot of bites at each other trying to make a consensus text. In the end, usually it's a very watered down, especially for people very technical and very ambitious in certain areas. But of course, the positive side is if there is a declaration, so we should take it as a political stance that the world is decided to do something about it. But just to say that the text should be taken more as a general bump rather than a very concrete technical text.
Probably got time for one more very quick one if anybody has. If not, no, because we have actually come to the end of our time on this session. Just time for a very quick few thank yous. Thank you obviously to MSD for supporting this session. Really, really appreciate it. Thank you to those watching here in the audience and also those watching around the world online a little later. And of course, thank you to our amazing panel, Dr. Ami Banerjee, Dr. Guilherme, Duarte, Olivia Ngou, James Anderson, and Dr. Zainab. Really appreciate your time. Thank you very much indeed.